Welcome back to the channel. Today, we're diving deep into Neuromyelitis Optica Spectrum Disorder, or NMOSD, a condition that, frankly, many clinicians still conflate with MS, but really shouldn't. At its core, neuromyelitis optica is defined by two hallmark features: recurrent optic neuritis, inflammation of the optic nerve causing vision loss, and myelitis, which is inflammation of the spinal cord. But here's the thing. Not every patient with NMOSD presents with both of these at onset. Some present with isolated optic neuritis, others with isolated myelitis. Some develop involvement in the brainstem, cerebrum, or other CNS regions. That's why we use the term NMOSD, Neuromyelitis Optica Spectrum Disorder. It's more inclusive. It captures the full spectrum of disease manifestations we see in the clinic, including partial forms and additional CNS involvement beyond the classic optic nerve and spinal cord. Moving on to epidemiology. NMOSD has a striking 9-to-1 female-to-male ratio, higher than MS. We're looking at a predominantly female disease. The mean age of onset is around 40 years, though it can occur at virtually any age. We see pediatric cases, we see elderly onset cases, but the population we most commonly diagnose is middle-aged women. NMOSD is recurrent. It's a relapsing disease. Patients have discrete attacks with periods of relative stability in between. While monophasic cases exist, single attack, no recurrence, they account for less than 10%. The vast majority will experience multiple relapses over their lifetime if not treated appropriately. And this is crucial. Disability in NMOSD accumulates from attacks, not from slow progressive pathology like progressive MS. Each attack can cause significant morbidity. In terms of prevalence, NMOSD is rare, less than 1 to over 4 per 100,000, depending on the population studied. It's not equally distributed worldwide. NMOSD is more common in Asian and African populations, significantly more so than in white populations. The highest prevalence globally is found in Martinique, likely due to genetic admixture and population-specific factors. In contrast, MS is much more common in white populations, especially in northern latitudes. Now let's discuss pathogenesis, because this is where NMOSD sharply diverges from MS. The discovery of the aquaporin 4 antibody in 2004 was transformative. It established that NMOSD is not MS, but a distinct immunopathologic entity. It's the target antigen in NMOSD which regulates water balance across the blood-brain barrier. Aquaporin 4, or AQP4, is a water channel protein found primarily on astrocytes, particularly on foot processes contacting the blood-brain barrier and in perinodal regions near nodes of Ranvier. When astrocytes lose AQP4, they cannot regulate water properly, and tissue swells. But that is only the start of the cascade. It's more than a marker, as its presence confirms the autoimmune nature of NMOSD. Let's now look at the mechanisms of astrocyte injury. Antibody binding initiates two major pathways: complement fixation and antibody-dependent cell-mediated cytotoxicity. Complement activation, via the classical pathway, leads to membrane attack complex formation and astrocyte lysis. ADCC occurs when immune effector cells, especially NK cells, target antibody-coated astrocytes. Both mechanisms converge on astrocyte destruction. Of course, antibody production requires T-cell help. Th17 lymphocytes recognize immunodominant AQP4 epitopes and drive B-cell differentiation. Normally, tolerance to AQP4 is maintained because thymic B lymphocytes constituently express AQP4 and interact with autoreactive T cells, promoting tolerance. In NMOSD, this tolerance breaks down due to genetic susceptibility, environmental triggers, or epitope spreading, and autoreactive B cells escape into the periphery, where they encounter activated Th17 cells, leading to AQP4GG production. It's important to emphasize that NMOSD is primarily an astrocytopathy, not a classical demyelinating disorder. Demyelination occurs secondarily. Pathology shows loss of astrocytes, loss of AQP4 staining, IgG and complement deposition along vasculature, thickened vessel walls, secondary demyelination, and paravascular inflammatory infiltrates. Here is the complete blueprint of NMOSD pathogenic cascade. The sequence is straightforward: failure of B-cell tolerance, production of pathogenic AQP4-GG antibody, antibody binding to astrocytes, complement activation and effector cell recruitment, astrocyte death, blood-brain barrier disruption, and secondary demyelination, like optic neuritis and myelitis. How do we know the antibody is actually causing this? Through passive transfer experiments. Researchers have taken AQP4 antibodies from NMO patients and injected them into experimental animals, and they reproduce the histologic features: the astrocyte loss, the inflammation, the demyelination. This leads us to the biomarkers of an acute attack. When you perform a lumbar puncture during an acute NMOSD episode, two findings are particularly important. First, IL-6 levels are elevated. Interleukin-6 is a key pro-inflammatory cytokine heavily involved in NMOSD pathogenesis. Its elevation in CSF reflects active inflammatory signaling and correlates with disease activity. Second, GFAP levels are elevated. GFAP, or glial fibrillary acidic protein, is an astrocyte-specific intermediate filament. When astrocytes undergo complement-mediated or ADCC-mediated lysis, GFAP is released into the CSF. Elevated CSF GFAP is therefore a direct indicator of astrocyte-targeted damage during an acute NMOSD attack, reinforcing that this is fundamentally an astrocytopathy rather than a primary demyelinating disorder. If you found this helpful, please subscribe and hit the notification bell. In the next part, we will discuss the clinical features, diagnostic criteria, treatment, and prognosis. We are just starting this channel, so your recommendations on how to improve future lectures will be highly appreciated. Please leave your suggestions and questions in the comments. Thanks for watching.